Well, I'm honored to be here, really. It brings me pleasure to share with you my experience and part of what our team has been doing, our work. I've been doing this since 2008, and I've been working with Dr. Feldman and Dr. Carley. When I started, did not know much about all of this, and I can still see Dr. Carley in front of me saying, "Debbie, do you know about ERAS?" And I go, "No, I don't." "You don't know about ERAS?" Well, let me tell you that that night, I was in front of my computer checking up what was ERAS. And today I do know a lot about ERAS. Anyway, before this, I was working in the pre-op clinic, and patient education plays an important part I think, in fast-track surgery. If you want a patient to participate in their care, I think they must first understand what is expected of them. So today my presentation would focus on the role that literacy and health literacy plays in patient education, as well as some of the strategies that may increase patient involvement. I'll also describe and show you some of the patient education practices that we have at the MUHC to support patient learning, comprehension, and retention. Before I start, I'd like to share how patient education has evolved during the years. Between 1900 and 1919, patient teaching was not mentioned in any literature for that period. Preparation for surgery was mostly in the home. In 1915, it was estimated that no more than 10% of people in the US received care in hospitals. For total physical and mental rest, the patient was kept in bed with no visitors for 24 to 48 hours before surgery. The nurse's responsibilities were to arrive at the patient's home a few hours early, pick up the instruments on her way there, choose the room, empty it of furniture, boil the sheets, and have it all ready when the surgeon got there. So needless to say, we did not address any emotional needs. By 1933, 80% of physicians were staff of hospitals in the US. Both mental and physical preparation of the surgical patients started to be addressed. The technical care was only one part of the nurse's duty. Mental prep of the patient also was essential, but patient teaching was not part of the pre-op preparation. During this time, we tried to set minimum standards of pre-op preparation. The nurse focus was mainly in preparing the operative site, preparing the instruments, and the room. Patients were admitted 24 hours before surgery, and most patients receive a plain warm water enema to flush their bowels. Between 40 and 59, the stir-up routine was introduced, and that was the responsibility of the nurse. It consisted of turning the patient, making him cough, do deep breathing and coughing, and deep breathing exercises. Early ambulation was defined as getting patient out of bed and walking within 24 hours after surgery. I wanted to point out when I was reading this article that in my hospital, we still have an issue about mobilizing patients post-op. In 1952, nurses were including early ambulation as being partly responsible for their increased patient load. So they had a problem then, and we still have it. The nurse was responsible to remove patients' fears that were based on superstition. And the pre-op and post-op patients were often separated to prevent them from seeing and hearing about frightening experiences. Patient teaching became part of pre-op preparation. Psychological prep of patient was recognized as important. Finally, between 60 and 79, there was greater emphasis on nursing research, and the link between pre-op preparation and post-op recovery was validated by nursing research. Pre-op surgical stress was recognized as having important consequences on post-op recovery. Actually, the classic research done in 1975 by Haywards showed that patients who had been given pre-op information required less analgesia and recovered faster than those who had not. During the 60s and the 70s, the nurse was responsible to assess patients' individual needs and pre-op instructions finally became an integral part of pre-op preparation. The importance of emotional, social, and spiritual needs became apparent, and pre-op preparation began to be practiced. Finally, structured pre-op instruction was introduced. Before I start talking about pre-op instruction and patient involvement, we must understand how health literacy plays an important part in all of this. Health literacy is fundamental to patient engagement. If people can't obtain, process, and understand basic health information, they won't be able to look after themselves well or make good decisions on health. Health literacy is not just about ensuring that patients can read and understand health information, it's also about empowering. I need to define literacy and health literacy. Literacy is the ability to understand and employ pertinent information in daily activities at home, at work, and in the community to achieve one's goal and to develop one's knowledge and potential. Health literacy and literacy are closely related, but health literacy focuses specifically on health information demands. Although there's many definitions today of health literacy, the Canadian Public Health Association defines health literacy as a person's ability to access and interpret information relating to their own health and their capacity to make well-informed decisions about their health. The Canadian Council of Learning stated the majority of adult Canadians, actually 60%, do not have the necessary skills to manage their health adequately. Health literacy is more demanding, and generally speaking, health literacy levels are usually lower than literacy levels. This is the island of Montreal. This map gives you a picture of health literacy in Montreal. It demonstrates the proportion at level 2 and below in percentage. Keep in mind, level 3 is the minimal level you need to function in an industrialized country. So low health literacy is more prevalent than low literacy. If 48% of Canadian adults have low literacy, 60% of Canadian adults have low health literacy. So the reddened area you see is mostly in the east part of the island, where there is a high percentage of low literacy. The more you go west, the low percentage of low literacy. And I want to point out there's a small island right in the middle. It's all red around, but that small island is called Nuns Island. Nuns Island is known to have many lawyers and professionals that live there, so I'm not surprised that it's a very green area. The Institute of Medicine reports that 90 million people in the United States, nearly half of the adult population, have difficulty understanding and using health information. And in Canada, 60% have low health literacy. Some of you saw this yesterday, but I think it's really important to know that low health literacy is really a problem everywhere. So 8 European countries participated in this survey to assess health literacy, and the results show that nearly every second person, 46%, across the participating 8 European countries had inadequate or problematic health literacy. There are several tasks and activities related to health literacy. We have health promotion, and under health promotion we have healthy eating and physical activity. Under health protection, we have safety at home and in the workplace. We have disease prevention. So a mother has to know how to immune and when to immune her child, and also all the screening that we have to go through. Under healthcare maintenance, we have monitoring our symptoms, knowing how to take our medications correctly. And again, system navigation, which means going in and out of healthcare facilities. These pictures were taken at my hospital. I'm not very proud of them. And when we wonder why people get lost. Nevertheless, to do all these tasks and activities, people need to be able to listen, speak, read, write, comprehend charts and forms, use basic mathematics, and problem solve. A person's health literacy skills are not fixed. For example, you may have adequate health literacy skills for getting a flu shot, but not necessarily to receive a diagnosis of diabetic. Health literacy is not only about education. A person who has finished high school and knows how to read may still not be able to navigate the health system. Health literacy comes from education, cultural and social factors, and health services. Who is most vulnerable to have low health literacy? Adults over the age of 65, adults with low income or the unemployed, immigrants, adults with low education. If your patient population includes many individuals in any of the groups mentioned above, it is likely that your practice includes persons with limited health literacy skills. It is important, however, to keep in mind that persons with limited health literacy do not fit into easy stereotypes. A cover article in Fortune magazine told the stories of several billionaires, CEOs, who had limited general literacy skills. As with nearly all poor readers, they had developed coping strategies that worked in their business and social lives, but might not work well in healthcare situation. Is there, excuse me. In 2008, the Canadian Council of Learning stated that the single best predictor of higher levels of health literacy is the act of reading every day, even more so than someone's education. So who knows, maybe one day the saying an apple a day keeps a doctor away might be replaced by reading every day keeps the doctor away. A review of studies examining patients' memory reports that 40 to 80% of the information provided by healthcare practitioners is forgotten immediately, and that half of the information patients remember is actually recalled incorrectly. Even with a skilled educator, the effectiveness of this method of teaching is limited by the patient's ability to remember what is said. There are two key players that contribute to health literacy: the patient and us, or the healthcare system. I don't think we can influence much other than the patient, but we can try to improve the factors under the healthcare system, such as using less medical jargon, using visual aids, using the teach-back method, reducing the speed of our dialogue, by decreasing the cognitive load and reinforcing verbal teaching with other methods, such as using educational material. Patient education becomes more effective. Are there any benefits to pre-op teaching? Several papers state that there are many benefits to pre-op teaching, such as overall better post-op outcome, increasing patients' involvement in their care and their satisfaction, decreasing their anxiety level. I found this pretty interesting. The Cochrane collaboration published a review on the effectiveness of providing written health information in addition to verbal information for patients and families being discharged from acute hospital settings to home. They concluded that parents had a better understanding of the care needed when given both written and verbal instruction rather than verbal instructions alone. Can pictures help in attention, comprehension, recall, and adherence? Talking about printed material, I like pictures, I like pictograms to make health education more attractive and just simply more fun to read. Patients, even those with good language skills, find it difficult to process medical information because they might be unfamiliar with the terminology, they might be preoccupied with their symptoms, they've just received a diagnosis of cancer, and because they are upset with all of this makes concentration difficult. While people at all literacy levels have problems understanding and using health information, people with limited literacy skills are especially in need of help. They need help in understanding written information, and because they place more trust on spoken explanation, they need help in remembering what they hear. But I think in general we can say that pictures can, in most instances, provide significant benefits. Evidence from reviews suggests that well-designed written information, such as leaflets, can be useful add-on to professional consultation and advice, especially if the information is personalized. Since many patients may forget what is said or might recall the information incorrectly, patient education material may improve health knowledge and recall. I think it promotes learning and increases knowledge. Patient may go through the material at home where there is less noise, less stress. They may review it and go back to it when they want. It's meant to reinforce the verbal teaching. It's not meant to replace it. If patients know about the treatment, they may cooperate with it better. I think it also promotes decision-making and self-management. I think some of you have heard this story, what I'm about to say. Some of you have been using it, I hear, but this is a true story. We created a patient education material, and every day is written, post-op 1, post-op 2, it is written what to expect, so the patient can read what to expect that day. So it's 7 o'clock in the morning, and the patient is sitting up in his bed, and he has his booklet with him. And the residents were all rounding, and he asked the residents how come his urinary catheter was still in, because according to the booklet, it needed to come out. And you know, when I heard that, it made me happy, because this is exactly what we wanted to. I wanted to make them more involved, more engaged in their care, not afraid to ask questions. And I think patients also expect to be well informed. At first, when we started to give the booklets at the pre-op testing day, we were asking patients to bring them back on the day of surgery. A lot of the nurses that I work with said, they won't bring it back, they'll forget it at home. I said, okay, let's give it a try. We asked them to bring it back, and it is under the things to bring to the hospital, number 1 is written, this booklet. And they do. I think I surveyed for about 2 weeks. It's short, but I don't have much time to survey patients to find out who's bringing them back. But for 2 weeks, I walked to the pre-op clinic, and I checked all the colorectal patients, and I think about around 20 or 22, there was 2 patients that had forgotten it home, and one was 17 years old, so I had asked her parents to go and get it. So I think in general, patients are bringing it back. When I visit patients upstairs, they have it on their table, they use it. I think family members also feel encouraged, because they can tell their family member what to do, if they can help them today to walk and so on, so they know a bit of what to expect. I think for the staff also, the staff, when you're in the pre-op, you're doing a teaching, they can use their time more effectively, especially if you have a booklet that covers pre-op until you go home. I also believe that staff benefits when they create the patient education material. They're better at teaching it. They can articulate the information better, and this facilitates knowledge transfer. When you create patient education material, it is imperative that you get feedback from other members of the healthcare team. So this in itself increases communication at all levels and promotes teamwork. I've gone up sometimes to a draft 14. When a surgeon gives me back, I will correct it. Another surgeon, I have gone to a draft 14. Draft 14 is usually where I say that I have enough. Is there a best way of teaching patients? No, no one method of teaching has been proven to be best, but using a combination of methods makes teaching more effective. Since you can't tell by looking which people have trouble, and no matter how well people read, most need help with understanding health information. Printed materials reinforce the messages provided in verbal teaching. They're not meant to replace them. Well-designed printed material can be valuable, time-saving tools in patient education. Plain language is avoiding medical jargon, no acronym, using familiar words. There are many types of educational material that can be used to support teaching. The goal is to make sure that our patients comprehend, understand, and retain the information given. The idea is that it's never just one way, but it can be a combination that needs to be individualized to the patient, the clinician, and your setting. So this is what we use at the MUHC. We use our patient education printed material. More and more we will go on the internet, and I'm going to show you clips coming soon. We have video, tape and DVD, pictures and posters, models, audio tapes, computer programs, or the internet websites. What about the internet? The internet is definitely getting more and more popular, and many people use it for health information. 2/3 of Europeans use the internet on an average at least once a week, and nearly 3/4 of European households had access to the internet in 2011. 4 out of 5 Canadians have internet use, and more than 3/4 of Americans had internet usage in their home in 2010. So if people are going to use the internet, we might as well give them reliable sites to go on. Just recently, I was doing a hip and a knee arthroplasty care pathway, and I always work with one surgeon, and I asked him, so give me some sites so that I can put in the booklet. He says, I'm not giving you any sites. And I said, but why? He says, because they're just going to ask questions. So I said, listen, they are going to go on the internet. They are going to look. You might as well give me reliable sites. And he did. So that solved the problem. But this is the logo, bottom left. This is the logo you would find on a website that would confirm that this website is compliant with the HON Code of Conduct. This logo confirms the revision of the site by the HON Code team at the above date. It respects and pledges to honor 8 principles. For example, one of their principles is advertising policy. It clearly distinguishes advertising from editorial content. The Mayo Clinic has the HON Code logo, therefore should be a reliable site to refer your patients. Also, I couldn't just not put ours, so you have the MUHC sites also that are available to view our patient education material. The Infotech and the patienteducation.ca is ours. In our patient education printed material, we give websites about anesthesia, about getting fit, about the surgery itself, and we reserve a section to smoking cessation. It's funny, in all my years working at the pre-op, I've heard many physicians taking data from a patient, and this is what I've heard. Do you smoke? Yes. How many cigarettes do you smoke a day? 15. When did you start? 20. Did you ever quit? No. And then we write it all down. And then what do? We move on to the next question. I think we should think that sometimes we should just say one line. There are benefits to quitting smoking before surgery. But I've heard often we just move on to the next question. So let's not forget that. One phrase. I've been very fortunate to be working with this group. It's called the MUHC Patient Education Portfolio Team and the McGill Mosen Medical Informatics in creating patient education material that I'll be showing you now. The content comes from our team. The layout, the template, the pictures are all created by the graphic artists. Now, this is the colon module. If you go on the colon module, you would get what is the colon cancer. Surgery. When you click surgery, it's mainly our booklets. Ostomy, chemotherapy, after treatment, and so on. If you click under colon cancer, this is what you would get. So what is the colon cancer, cancer spread. I'm going to show you some clips after this one about the ostomy, because I think the ostomy is a bit more complicated and could sometimes delay patients from leaving if they haven't had proper teaching. So hopefully this is going to work. Here you go. So these are not meant for patients to view alone. Some of them are meant to view with the surgeon. Some are meant to view with the stoma nurse, in this case. Some of it also will be started at the pre-op clinic. I hope that the nurses of the pre-op clinic will be open to start viewing these with the patient. Now, I'm not going to show you the whole thing because I don't know how much time I have left. But it has movement, as you can see. I'll finish this one, and I think I won't be showing you the 2 others. Okay, I'll skip it. This is boring you? And there's another one, I'll skip that one too, since I only have 5 minutes left as well. So this is a standard that we have at the MUHC. We have a document that helps staff who want to create patient education material. I use this guide, I think I know it by heart. It gives you basic instructions and pointers and standards if you want to write a patient education material. For example, it tells you to choose your words carefully. Use grade 6 or 8 level literacy. Use you throughout your document. I truly believe that you can't create a care pathway and leave the patient education material out of it. It's part of the care pathway. Once you get the medical orders, the medication orders, the nurse's documentation, all the documents you think are important to get into that care pathway, you need to create a patient education material to help the patients and family understand and prepare for their hospitalization. So what I'm trying to say is that before we arriving to this guide, we go through a lengthy process. Once you plan the care pathway, you must remember to plan and prepare a patient educational guide that goes with it. One standard I wanted to show you is when showing internal body parts, include the outside of the body, avoid cutting off body parts. Because if I would be showing this to my 83-year-old dad, he would not understand the liver. He'd probably think it's a Napoleon hat and une grosse bibite en dessous. But instead, if I would show him this, he would probably be able to relate to it much better. The following slides are our patient education booklets. So we explain what is the bowel, difference between lap and open. We encourage a 15-minute walk is better than nothing. We talk about the epidural. Recently we've added a PCA. Exercise as soon as you wake up. As soon as you get into your room, you get out of bed and you have a protein drink. Notice we have gum. I was very proud of my gum. Dr. Kellett came and visited us 2 years ago and he didn't know we had our gum, and he went in front of the amphitheater and he says, "We're not using gum." And I felt like saying, "Yes, we are." And he says, "Maybe it's not because it's just not expensive enough." So I was pretty happy to show that we were using gum. So people are told to bring 2 packs of their favorite gum, and they start chewing gum in the evening for about 30 minutes. The pain scale, 2 days, 3 days, they go home. Pain diary. And just recently we've added a patient log. This is very helpful for the person who's doing data collection. Our charting is not that great, and when we're missing charting, he also refers to this to put in his data. I believe everybody saw the pictogram. This is the cover of our patient's book list, and I will finish my presentation by saying that even though we live in an industrialized nation, our literacy level is low and will not increase in the next 20 years. There are things we can do, tools and strategies we can take to help patients understand better and get involved into their care. Increasing the health literacy level remains at the foundation of patient involvement. We know there are several benefits for surgical patients to receive pre-op teaching. However, not many studies look at when is the optimum timing to do this and what is the best method of delivery. Creating patient education material is a critical component and an important step in the creation of a care pathway. Thank you.